Huon.
Thank you very much, Mr. President. I didn't prepare a formal speech, but please allow me to make a couple of comments because it really is an interesting area that we should be dealing with. And when we talk about health legislation, health regulation, I think we should be focused on one thing and one thing only, that's the patient. And we've got to really be committed to ensure that the legislation and the regulation is meeting the needs of patients. That's all. It's actually not that hard. And I think it's very clear, listening to honourable members, that the current scheme that we have in Tasmania certainly doesn't meet the need of vulnerable patients who have tried everything else in the medical textbooks and really don't find answers in that, and therefore are looking for alternatives and find relief in medicinal cannabis products that currently are, unapproved and unregulated. I think it's probably fair to say, and I've mentioned this before, that prescribing and regulating and accessing medicinal cannabis in Australia is pretty much a basket case. It is what it is. And I, for years, have been asking for a nationally consistent regulatory framework for access and prescribing of medicinal cannabis. It shouldn't be that hard. And realistically, when I was national president of the College of GPs, we had very positive meetings on a federal level with the Federal Minister for Health, the Honourable Greg Hunt. And he was committed to introduce a nationally consistent regulatory framework. And of course, in order to do that, you would need to get the states on board. So my role was to speak to respective state health ministers on that. And I didn't have much luck with the Tasmanian health minister at the time, the Honourable Michael Ferguson. And it didn't make any sense to me at the time why we would consider unnecessary barriers and create unnecessary burdens, considering that, we could focus on a national body, and it was the TGA that was proposed as the one-stop shop for approving medicinal cannabis products. And it didn't make any sense. So we progressed that in January 2018. Other states like New South Wales committed to a framework and they reduced their barriers. In March, New South Wales decided just to have the TGA as the one-stop approval point. And it was meant to be discussed at a COAC Health Ministers meeting in April 2018. I know they did discuss it, but unfortunately, Tasmania stood quite firm and said, no, we're not going to be involved. We do what we do. And here we are, 2020 doesn't seem to work and it's completely unnecessary. And I'm getting a bit upset when I'm hearing, but we have a special access scheme and compassionate access scheme, and we are the only state, in the Commonwealth that subsidizes, medicinal cannabis when approved. That's fair enough. But it's almost like a spin doctor talking rather than a real doctor talking, because you could do this much, much easier. You could just commit to subsidize each and every medicinal cannabis product that was approved by the TGA. End of story. So the Secretary of the Department of Health could do that, or her delegate. Create a stamp, just put approved. There's no need for an extra committee. There's just no need, because the product is already approved. The application has been made to the TGA. The TGA has appraised the application. And if the TGA approves it because they feel it's appropriate for this patient to have access to medicinal cannabis, then why would you need to have another body approving what's approved? That body in Tasmania could just say, yes, if it's approved by the TGA, then we subsidize it. That's it. So if you want to reduce red tape, we can do this now. We don't have to wait for anything. Trust the TGA to do the right thing. And they are doing this nationally for each and every state anyway. Yeah. And, to be frank, cannabis isn't that special. It's just medication. It's not that special. It's not that different to other medicines, really.
Which is a lot less toxic.
I cover that in a minute. Because, if we look at things that are readily available, like opioids, for example, that seems to be straightforward. Anybody can prescribe it. Junior doctors can prescribe it.
That's much more harmful.
Much more harmful. But I remember when I went to medical school, we were told nobody should be in pain, and the solution for pain is to prescribe opioids. And when I was a GP, we got called out because GPs were not prescribing enough opioids.
Well, look at the opioid crisis all around the
And we
world
were
now.
told it's safe and we should be, prescribing more. And how dare we GPs aren't educated enough because we don't prescribe, opioids. That was the big industry push. And, pain specialists all got trained up and they pushed us GPs to prescribe. And see what happened. We were told the evidence is great. All the guidelines say the evidence is, really strong. And, 20 years down the line, we have a bit of a problem. A huge issue. But it's getting worse. Now we know opioids don't work for chronic serious disabling pain, but we prescribe it regardless. And we approve it regardless, and the PBS subsidize it regardless. It doesn't make any sense. But for medicinal cannabis, which is not a panacea for all, but might well be the appropriate medication and treatment of last resort for a small number of people, we just create these unnecessary artificial barriers. Doesn't make any sense. It doesn't make any sense from a scientific point of view. It doesn't make any sense from a medical point of view. It doesn't make any sense from a common sense point of view. And we are failing our patients, and we've heard the stories over and over again. And it's sad. And, honorable Lieber, when the Tasmanian scheme was introduced, I certainly referred a patient of mine with chronic pain who've tried everything, absolutely everything, all the standard medicines. We've done acupuncture, we've done psychology, we've done exercise physiology, you name it, he's done it. And I referred, for an assessment to consider medicinal cannabis, per fax, and I got a letter back, handwritten, we don't offer that service. And then the patient stays where he is. And he says, well, I just have to grow my own then. Because he wasn't going to use any of the other stuff I've tried. I've tried a lot. So again, it's not many, but there are patients out there. And the current scheme, as we have it now, is failing them. And I think to continuously say that we are the only state that subsidizes financially medicinal cannabis, I'm not sure that's going to fly. So I talk a bit about, what we're looking for evidence, and I heard what the Honourable Member for Mercy said with regards to more trials and more science. And yes, scientists and medical research always ask for more trials and so forth, and that's great. But I want to put on record that, there is conclusive evidence that cannabis or cannabinoids are effective, and now it comes, for the treatment of chronic pain in adults, as antiemetics in the treatment of chemotherapy-induced nausea and vomiting, for improving patient-reported multiple sclerosis spasticity symptoms. Conclusive evidence. And Mr. President, that's not my opinion. Right? It's not my opinion. It's the opinion and the conclusion of the National Academy of Sciences in the USA, who published their seminal work on health effect of cannabinoids in 2017. Now, remember, that was not a quick review. It was not a hush job, because since 1999, when the initial Institute's report was released, there were an additional 24,000 articles, published and reviewed by the National Academy of Sciences. And they reviewed and appraised each and every one of them. And so they should. Because there's really nothing, the Academy can do better but appraising evidence. That's what they do. It's a great institution, funded in 1863. They're funded through a $500 million endowment, and they consist of over 2,000 members, 1,000 staff. 190 of their members have received a Nobel Prize. If there's anything they can do is, they can establish scientific facts. And I think we certainly have the highest level of evidence. That's 2017. And yes, there are more reviews and more science and more research papers since. Of course they have. And, science is always going to evolve, and it should. But I want to be quite clear that just we have one area where there is absence of evidence doesn't mean there's actually evidence of absence either. You have to be really quite mindful. So there's a difference between absence of evidence and the evidence of absence. And realistically, we in health, we are doing off-label prescribing already. It's a common practice. Routinely we are doing off-label prescribing. And we do this in particular for people at risk, children. Most of the medicines we use for children haven't been through, rigorous randomized controlled trials. It just haven't. We are prescribing based on the safety profile of the medication. We are prescribing based on, surrounding science. And that's why the honorable member for Merchant is right. Cannabidiol, one of the, over 100, chemicals in the marijuana plant, is actually very safe. It's impossible to overdose. You can't. You need half a ton, for cannabidiol. It's not going to work.
That's right.
It's not going to work.
Some people might give it a good shot, but
you can't. You would be crushed rather than poisoned by it. That's how much cannabidiol you actually need. With regards to THC, that's a bit of a different story because, there are potentially psychotic effects, and mental health effects. So we know that. But again, we can distinguish. It's entirely reasonable, and cannabidiol has been well studied, and we know it's safe. Right. So if we know it's safe and we know it's indicated, why are we not allowed to prescribe it? It shouldn't be that hard. It really shouldn't be that hard. And we can do this now. Again, we could go on and on and on. How do we monitor for long-term effects and long-term trials? That's all been discussed extensively. We can do N of 1 trials. We can do a central register. It's all possible. The models already exist. It can be done tomorrow. It's not that hard. And I welcome the availability now of low-dose cannabidiol products as Schedule 4 pharmacy-only medications. It's the good starting point. It also indicates to the wider public that those medicines actually are safe. But again, what I also don't want is that patients are now going from one pharmacy to another pharmacy to the other pharmacy just to get more and more of those, low concentration drugs. Let's have a common sense approach here. Regulate appropriately and remove unnecessary barriers. The current scheme, what we have in Tasmania, is a barrier. There's no benefit for it. And if you want to subsidize medicinal cannabis, great. Subsidize each and every drug that's been approved by the TGA. And the TGA now has a turnaround time of less than 4 days. Yeah. Online only, less than 4 days. And GPs could just directly refer to the TGA for an approval process. That's how it should work. It's not that hard. So I certainly commend the member for Windermere for his motion, and I fully support it.